Welcome, everyone. Hello. It's another installment in our Pediatric Hospital Medicine podcast series. If you're keeping track, this is episode 12. We're coming to you from Children's Hospital of Pittsburgh in Pittsburgh, Pennsylvania. I know it's been a while since our last podcast, roughly right before Christmas, but as you all are feeling the pinch of winter, so am I, and so are we. So it's been incredibly busy, so I apologize for the delay. Just to remind you, my name is Dr. Tony Tarchichi. I'm a Med-Peds trained pediatric hospitalist here at Children's Hospital of Pittsburgh in the Paul C. Gaffney, now Division of Pediatric Hospital Medicine. We have recently changed our names. This is a great episode we have for you today. We're going to review the core competencies on newborn care and delivery room management, which we're all very excited about. Let's do our disclaimer. I'm going to do it, and I'm going to tell you a couple things before we start. First, this podcast is for general, informational, educational purposes only, and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Well, I'm going to give a disclaimer on our own group. We do not do newborn medicine. We do not do newborn care. So this is something, through moonlighting I've done a tad bit, but really not much. So we do not do this on a regular basis. So this was a hard podcast for me to do because it's not something I practice regularly. But I know in pediatric hospital medicine, a lot of people, and in fact most people, will do some newborn care, whether it's delivery room care, whether it's newborn nursery. It's a regular part of being a hospitalist, and in most jobs that's half or more of what you do. Along those lines, my guest today is uniquely qualified to help me with this podcast as the expert guest. Her name is Dr. Arcangela Balest, and she earned her degree from the University of Pittsburgh School of Medicine, completed residency in pediatrics at Children's Hospital of Pittsburgh, was then a fellow in neonatology at McGee Women's Hospital here in Pittsburgh, or UPMC. She was a director of the Division of Neonatology at Allegheny General Hospital. And when she was there, Allegheny General Hospital shut down their NICU for a while. Then we were lucky enough to have her join our group, which was then the Paul C. Gaffney Diagnostic Referral Service for 5 years as a hospitalist. And we were fortunate to have her skills with us. And then she joined Children's Hospital of Pittsburgh of UPMC Division of Neonatology, where she works now. She also has expertise in the area of feeding problems in infants and children. So, Dr. Balest, thank you very much for joining me today. I really appreciate your time.
Thanks, Tony. I'm happy to be here with you today.
Let's do our disclaimers. So, as usual, I have nothing to disclose.
And I as well have nothing to disclose.
And also, before we start, we are bringing back the corny joke segment. So in between us going through these core competencies, we will be peppering you with jokes that I find funny, and you may or may not. We'll see. So looking at the core competencies, they're long and they're very general. And this is going to, for those of you listening at home who have listened to these before, this is going to seem familiar to the palliative care and the child abuse segments we did, where it's basically covering almost an entire fellowship in a couple pieces of paper. So it's challenging to do that on a podcast, but we're going to give it our best shot. So one of the first questions they ask is describe the role of each team member commonly involved in newborn care, including the obstetrician, prenatal ultrasonographers or radiologists, primary care providers, nurses, lactation consultants, and others. So I really felt before we did this, we really should go into the question that discusses the differences and definitions of what is a level 1, 2, or 3 nursery. Because I feel like before we get into who's there, we should know where we are and why. Dr. Balest, would you mind talking about just the differences between levels 1, 2, and 3 nurseries?
So the grading system for nurseries really comes from a document that the March of Dimes put out in 1976 called and I don't really know if people refer to it as the TOP document or TIOP, but TIOP stands for Toward Improving the Outcome of Pregnancy. And so in that document, the March of Dimes, who at that point had turned their efforts from preventing polio, preventing that disease, to preventing prematurity, stratified neonatal care into these 3 levels. And so while we all talk about level 1, 2, and 3 nurseries and and use that to think about how sick somebody is based on where they came to us from. Recognize that not every state has the same definition of levels of care, and so while this is a document of guidance, these are not uniform national. This is not a national way of organizing. So a level 1 nursery is just routine newborn care. Babies who don't require anything other than the routine things provided. Eye prophylaxis, vitamin K, and very rudimentary monitoring, not with any cardiorespiratory monitoring or pulse ox care. Level 2 nurseries are nurseries that provide level 1 care and level 1 care meaning term babies, so babies late preterm as well as term babies, so anybody over 36 weeks or 36 completed weeks. Level 2 capabilities then are providing care to babies that are born greater than or equal to 32 weeks, greater than or equal to 1,500 grams, and who have problems that are expected to resolve quickly, including respiratory problems. So a level 2 nursery, and again, defined differently in different regions, but for the most part, we understand that a level 2 nursery is a nursery that can provide some respiratory support, so which a level 1 cannot do, some respiratory support in the form of CPAP or even intubation and ventilation, but for a limited period of time, less than 24 hours mainly, and could also stabilize an infant born under 32 weeks or under 1,500 grams until transfer to a higher level facility, which would then be a level 3 facility. So level 3 care is babies born after what's considered viability, so 23 to 24 weeks, who require advanced respiratory care, so intubation, ventilation, and have also available consultants that can provide specialty care, and including surgical care and consultation.
That's great. That's interesting. So I didn't realize they were divided by weeks so clearly. 32 to 36 or 37 is level 2. Most hospitalists need to be comfortable up to a level 2 nursery to handle, I guess, simple things such as transitioning if you're a C-section patient, transcription, either newborn or neonatal abstinence syndrome. In terms of these strict definitions, we know that sometimes things go awry, and especially if you're practicing in a more isolated area where it's hard to get to, you may not have a neonatologist for a while. So these are somewhat fluid, so a hospitalist could end up managing a level 2 for a longer period of time if they're intubated more than 24 hours while someone's coming to get the child. Sounds right?
Yes, although the goal, and again, not strict regulations, but the goal would be that that child would be able to be transported out before 24 hours or around 24 hours. The other thing to keep in mind, though, as well, is I've had to remind myself of this at several points in my career because I've covered at level 2s, and you feel like, well, I know how to do this. But you have to remember that there's a lot of other people supporting you that may not be able to provide that level of care. So in particular, what I mean is you can take care of the ventilator, you know how to make adjustments. You don't always have respiratory that's comfortable with an infant on a ventilator. So, and that's part of when we talk about setting up our team, we need to make sure that this person might be quite competent taking care of an adult on a ventilator, but an infant on a ventilator is a whole nother thing. Or even something as simple as a baby isn't tolerating feeding. Well, we'll just provide some Hyperal for a period of time to get the right calories until we can get the feeds up. But your pharmacy at a level 2 hospital, at a community hospital, might not be able to have the right trophamine concentrations for neonatal Hyperal. Or the nurses, while you know how to put in the UV line, they don't have protocols in that hospital for maintaining a central line, which is what a UV line is. And that actually is the case at a level 2 hospital where I cover now for our hospital. We have a contract with an outside hospital, and we provide services there, and sometimes I go out to cover the doctor that's there usually, but we know we can't keep a UV line there. We can put one in urgently, but the nurses there don't have protocols to maintain them.
That's a great segue into our first question that we kind of shied away from, which is knowing your team members. The obstetrician, ultrasonographers, I guess we've added now your pharmacist even, your respiratory tech, besides the nurses, and even lactation consultants. So this knowledge-based area is somewhat vague. How would you go about explaining this to those of us, people who do it regularly, but some of us who may not?
So those in the audience that are more experienced will recognize what I'm talking about. Those who this is your first job out of residency or fellowship, what you hope is not what has happened to me, is that you say, Joe doesn't know how to run a neonatal ventilator. So when you get to that hospital, I would say it's hard for all of us to think of ourselves as experts, but you're going to be the pediatric expert in that setting. Hopefully you have a group of people supporting you, other doctors, but sometimes you're the only doctor with pediatric knowledge in that hospital. So the first thing I would do is advise you to meet with these various departments. Think about who supports you every day: the nurses, respiratory, the pharmacist. Who do you interact with? The OB, the nurses in labor and delivery. Those are all the people that you either have to help become competent or know what their abilities are. And even though we're talking about provision of delivery room services, sometimes people come in and deliver in the emergency room, right? And you're going to interact with those people. Recently, again, at this hospital, we got a call to the emergency room that a lady was coming in with a baby being born breech. The head was stuck in the vagina, and baby, I think, was 30 weeks. This is a level 2 hospital. So number one, I had to figure out where the emergency room was, right? So that's not when you want to do that. So again, we had to take over. Like I said, this is a hospital where I don't cover every day, but asking for things like a warmer, give me a French fry light. So that's the kind of thing that you don't want to be working through at the time when the 30-week baby's coming in stuck, that you want to know that all those people understand what your needs are. So any place where you might interact in the hospital, it's a good place to start.
Not to belabor, the ultrasonographer question stands out interestingly because we get a lot of transfers, just like most children's hospitals get a lot of transfers. And one of the things we get transfers for now is our radiologists are not comfortable reading an ultrasound, or the ultrasonographers can't do an ultrasound on a child this young. For us, it's looking for appendicitis or looking at the abdomen for something. But for an infant, I have to assume that's even a bigger issue. So if you need an ultrasound for a brain looking for any type of bleed, or checking whatever, UVC, or something like that, it's really imperative that you probably talk to your radiologists and ultrasonographers to see what their comfort levels are and what you may have to transfer it out quickly.
That's right. And so it's not just the ability to perform and interpret the test, but it's also part of having that ability, it's having the equipment, so the different size probes. So there are some things, because again, it's a level 2, so you're not going to expect the ability to really care for the problem, but you should have some ability to diagnose. And so I would say that the things that are critical to have are head ultrasounds and echoes, because those are the things that come up most, particularly with an infant that maybe was transferred back to your level 2 and needs follow-up of something like the echocardiogram or follow-up of a head ultrasound for a bleed.
All right, let's begin the segue into our next one, which is review the basic physiologic differences between the preterm and term infant, attending to cardiopulmonary needs, respiratory control, feeding issues, and other elements. So, Arc, I'm going to give the microphone to you.
Okay. So we've touched a little bit on this, and really you're going to hear me refer a lot to the NRP course. And so I think that the NRP course, and now with the ability to certify online and go through the scenarios online, is really an excellent resource, because you can access those things as many times as you need to. So what I'm going to talk about is essentially covered there. So I would refer everybody to that if you need refreshers. But essentially the main differences between the term and preterm infant, not just size, which is obvious, but related to needs for support. So even though you're at a level 2 and you're only supposed to handle babies over 32 weeks. Everybody knows that pregnant ladies come in and deliver babies that they shouldn't be delivering at your level 2 hospital. So you need to be prepared for that. And so being prepared for an extremely low birth weight baby, meaning somebody under 1,000 grams who may be as young as 23 to 24 weeks, means that you, number one, can manage the airway. And so you should be certified, and you may be the person to take care of certifying those around you, like the people in the DR, the OBs, the labor and delivery nurses, the nursery nurses, and like I said, even the ED. So that's part of your preparedness, making sure that everybody who will be in delivery rooms is certified in NRP, so that when you ask for things, again, you're not going to expect that labor and delivery room nurse to take over. But if that 24-weeker comes out before anybody else is in the room, she'll have some knowledge about, he or she will have some knowledge about how to handle that baby, and to at least begin positive pressure ventilation and know the steps to keep that infant warm. And that now involves having bags in the delivery room. We have plastic bags to put the very small babies in to maintain temperature. So again, making sure you have equipment and making sure that everybody is properly certified. So temperature regulation, airway management, and can you maintain the central lines, even for the period of time that it would take for a transport team to get to you.
Along with the airway, can you talk about the use and needs for surfactant? Would we really ever use it in up to a level 2 nursery?
The first thing that you need to establish as a covering hospitalist at a level 2 nursery is whether the affiliated level 3 nursery wants you to use surfactant. Because using surfactant, so the indications to use surfactant would be evidence of RDS, evidence of premature lung disease on chest x-ray, and a baby, premature or not, requiring a level of ventilator support, and like I said, confirmatory x-ray changes. But providing the surfactant means that you know how to manage the ventilator and that you can handle the changes in compliance that will happen in the lungs, sometimes very quickly. So the settings that you use before the surfactant may need to be changed relatively quickly after you provide the surfactant, because the lung compliance will change. So before you make the decision to provide surfactant in the setting of lung disease of immaturity or a baby with severe meconium aspiration syndrome, we know that surfactant in those cases, although does not affect mortality, will decrease the need for ECMO. So that's another indication for surfactant. You need to make sure that you can handle the lung compliance changes, that your backup hospital is okay with that, as well as it's expensive. And so if you're at a level 2 hospital that maybe has the need to provide surfactant for a baby once a year, pharmacy may not want to stock it because it'll expire, because it's a big cost for something that they may have to throw away in a year or in less than a year. All those things need to play into your decision process of whether you, as the hospitalist at a level 2 nursery, will provide surfactant.
So surfactant isn't something you need to do in the delivery room. This is something when the baby is stabilized in the NICU or the nursery, while you're waiting for level 3 to come, or the neonatologist to come. They can make that decision with you, but it's not something that you, let's say a baby comes out. This is obviously a 24 or 25 weeker. The mother wasn't supposed to be there. It's not something you have to put in right away.
So ideally, the sooner the better. And at level 3 nursery at a delivery service that has a level 3 nursery attached, when we know a 24-weeker is being born, we'll go to the DR with surfactant. So yes, ideally you would provide it as soon as possible, but it's not absolutely necessary. And that's why I say that decision should be made in conjunction with the people that are supporting you, mainly your referral, the nursery that you'll be referring to.
That's great, Art. Thanks. One of the things I promised is we are going to do our corny joke segment again, interspersed throughout. And I am actually going to ask our guest if she would mind giving the first corny joke, and you can pick the one you like.
I like this one. What did one cannibal say to the other cannibal after they ate a clown? Did something taste a little funny to you?
I do love these. Okay, Ark, that was fun. Let's get back into our core competencies.
Something to familiarize oneself with would be gestational age assessments. So not that you would transfer a baby just because on a Dubowitz or a Ballard exam that baby, if they don't need any respiratory support because they scored that they were 31 weeks or 30 weeks. But if they have that score, then you need to think, even if they don't need any respiratory support, you need to think about all the other things that they will need, like slower initiation of feeds, moving up more slowly to full feeds. That baby then is less likely to develop a matured suck, swallow, breathe reflex within a week or two, and might need prolonged TPN until you work the feeds up. As well as you also need to pay attention to what were the events around the delivery. So if the baby had any hypotension or you see evidence of other organ system involvement, you would need to advance feeds possibly more slowly, recognizing that baby, not just by virtue of their gestational age, but because of the events of the delivery, is a little higher risk for NEC. And again, knowing what your team can provide. So if you don't have protocols to maintain UV lines, that might be a baby, even though they don't need a lot of respiratory support, you might consider transferring earlier rather than later.
So along those lines, I trained in Newark, New Jersey, and our nurses primarily did in the NICU, the assessment as to whether the child can go up on the feeds or not, along with supervising. At other places, do the speech pathologists get involved, or is that really primarily NICU nurse and NICU attending or hospitals attending kind of a thing?
So I think that depends where you are. So just like respiratory issues, in some nurseries, it's the respiratory therapists that are deciding the weans. In others, it's the neonatologists, and in many, it's again more of a team effort. Same thing with the feeding. We here have protocols for how we advance volume, and we're trying to standardize amongst ourselves. We do have speech involved here at Children's, but not at the delivery hospital, which is McGee. But they are not seeing everybody. They see everybody, or they see patients for whom they've been consulted. So patients with difficult feeding, persistent bradycardias with feeding that have persisted beyond the age where we think that it's just due to prematurity.
All right. Discuss the impact of maternal factors on the fetus and newborn, including abnormal prenatal labs, maternal diabetes, thyroid disorders, and prescription, non-prescription, and illicit drug use. Now, for those of you listening, we are going to talk about neonatal abstinence syndrome. I hope this time there's a lot to cover, but that is something we're planning on talking about, and I've done the legwork to help talk about that along with Arc. So I don't know if we're going to get to it here or not in this particular podcast, but it will be a podcast at least, if not a part of this one.
So luckily, the things that you need to know before the baby is delivered are such a routine part of the documentation in OB that you rarely don't have that information unless somebody comes in urgently and delivers, but it's usually somewhere in that prenatal chart. So luckily, this is not the kind of information that you need to go digging around for. So you probably recognize that whole format and the way they document. This is a so many gram, born to a so many G whatever, P whatever, A positive, rubella immune, RPR. So we know all those things. So going through those serologies and that data one at a time. So at every delivery, you should know the maternal blood type and antibody status. So not just that she's A positive, but whether she had any positive antibodies. And so other than the anti-D from Rogam, the baby should have a type and Coombs sent immediately after birth for any antibody positive in the mom. So aside from anti-D for Rogam, if the mom has any antibody positive, you should check the baby's type and Coombs right away.
When you say other than anti-D, that's already been done, we're assuming.
No, so anti-D, mom is positive for anti-D because she got Rogam. So she's Rh negative, okay?
So any antibody positive, we check the infant right away. This particular area is huge in terms of what we're going to have to talk about, so we're going to break this down one by one. So, Arc,
next is her rubella status. If mom is rubella non-immune, which happens infrequently, but it happens, this is very important to know, particularly if the baby has any clinical features that you think are consistent with congenital rubella syndrome. So, meaning something like a rash, like the blueberry muffin rash. So, acute illness, hepatosplenomegaly, viremia presenting like septic shock, even microcephaly, all that should trigger an evaluation for rubella in the baby if the mom is rubella non-immune. Knowing mom's syphilis status is important. So there is usually some non-treponemal test on the mother's chart, either an RPR or VDRL. But keep in mind, if that baby shows signs of congenital syphilis, that negative testing does not guarantee that the mom does not have syphilis. In primary syphilis, your non-treponemal testing may be negative. So keep that in mind. If you have a baby that shows signs of congenital syphilis, again, something like the snuffles, a baby who has rash, particularly on the palms or soles, baby who seems to have little movement from a periostitis, so little movement of an extremity, all those can be signs of congenital syphilis. In that circumstance, the baby should be screened immediately. If the baby's titers are higher than the mom's titers, then that's usually a pretty firm sign that there may be congenital syphilis, and you would also do treponemal testing on both the mom and the baby. And obviously by this point, if you're suspicious at all, you should be consulting ID. And if you don't have ID at your hospital, you probably have a relationship, or PEDS ID, you probably have a relationship with the community or with a children's center where you can get some advice, and I think even an adult ID person could be useful to you in that circumstance. Hepatitis status. So let's talk about, in particular, hepatitis B. If the mom is hepatitis B surface antigen negative, then the recommendations now are to provide the vaccine within 24 hours, and this is for babies over 2 kilos. If the baby is under 2 kilos, provide the vaccine at a month or at discharge, whichever comes first. But this is if the mom is hepatitis B surface antigen negative. If the mother is hepatitis B surface antigen positive, then the recommendations are to provide HBIG and the vaccine within 12 hours of delivery and at different sites. And here there's no proviso about size. So anybody where the mom is positive, provided at 2 different sites. And that's just so that the immune globulin isn't binding up the vaccine. Now, if the mom is hepatitis B surface antigen unknown and the baby is over 2 kilos, you would give the vaccine within 12 hours. So if she's negative, even though we say as soon as possible, give the vaccine within 24 hours. If she's unknown, the recommendation is to give that vaccine within 12 hours and hold on the HBIG until you confirm if the mom is positive or negative, and you have up to 7 days to provide that HBIG, but you should have your results back on the mom before 7 days. If the mom is unknown and that baby is under 2 kilos, then the recommendation is to give the vaccine and the HBIG by 12 hours of life unless the mom is confirmed negative in that time period.
You would see, of all the congenital potential infections, this is one I remember seeing more than most, more than syphilis, more than HIV, more than rubella. Hepatitis B question was something that came up frequently.
Oh, yeah. So not so much that we see babies with hepatitis B, but yes, these moms come in with this unknown status. Yes. So now we have easy guidelines to follow, and these are easy to find. So, since we're talking about hepatitis, let's talk about hepatitis C. Universal screening is not yet recommended for pregnant women, although lately in the ACOG documents, there's a lot of talk of that. But for now, it's not yet recommended, but there is a 5% risk of transmission to the infant during gestation, so it's a relatively high risk. Infection during pregnancy can be associated with IUGR and low birth weight, and we have antiviral treatments now that work for hepatitis C, but there's no recommendation for their use in pregnancy. So keep that in mind, that you won't, don't think of it as something that now we can treat with good outcomes. There is no need to discourage breastfeeding in the mom, and really the reason for you to know about hepatitis C positivity in the mom is so that you can be sure to notify whoever's going to be following that baby, and so they know to check that baby's titers at 18 months of age.
Just for those of you listening who may not be familiar with our acronyms, IUGR is intrauterine growth restriction, and this is someone normally you would consult Peds ID just so they know about the patient and will follow up with them, but that may be location specific. In some places your primary medical doctor is comfortable doing it, because just to screen at 18 months after the initial birth, right?
Yes. So here, even at the community hospitals, we don't consult ID. We just make sure that it's well noted in the chart so that PCP knows to send titers. I imagine that if that baby comes back positive for hepatitis C, then they do send them to ID.
So let's touch on HIV status.
Okay. So if the mom HIV positive, let's start with that. If the mom is HIV positive, so she likely is on an antiretroviral treatment during gestation. So this is approved in pregnancy to prevent maternal to fetal transmission, and she should be getting IV Zidavudine. And the recommendations are that mom undergo elective C-section of 38 weeks if her RNA load is greater than 1,000 copies per ml, or if her load is unknown. The routine then is to prophylax the infant with ZDV or Zidavudine. I'm going to say ZDV from now on, for 6 weeks if she's unknown positive, and even though she was on an antiretroviral during pregnancy. Sometime, and again, so Pediatric ID will usually handle this for the follow-up, and they may add a second drug in certain circumstances. You should begin the ZDV as soon as possible after birth, preferably within 12 hours. In this circumstance, so unlike in hepatitis C, for HIV positive moms, we counsel them against breastfeeding because there is around a 10% transmission rate during breastfeeding, transmission of HIV to the child. You should also make sure that you have documentation in an HIV positive mom of other status like Hep B, syphilis, toxo, TB, and HSV. So toxo not routinely checked prenatally in centers. HSV not routinely checked unless mom has had an outbreak. So I think, though, if somebody's HIV positive because of their immune compromise, you should know that as well. The recommendations, and again, you would likely have a Peds ID person involved here, but the recommendations in an HIV positive mom is to test the infant at 14 to 21 days with HIV DNA or RNA assays, and if it's negative, repeat at 1 to 2 months, and then again at 4 to 6 months of age. And consider even earlier testing if mom had a very high viral load. Again, all this under the guidance of an ID specialist. So that's if mom is HIV positive. If mom is HIV unknown, then it's recommended that you get rapid HIV testing on the mom before birth if possible, or on the infant as soon as possible after birth, and preferable on the mom because rapid testing is not validated yet in infants, but it's very sensitive in adults.
Now let's take a second and do a couple more of our corny jokes. I'm going to do one and I'm going to pass one to my colleague. What do you call a sleepwalking nun? A Roman Catholic. I love that. Okay, and now, Arc, you're up.
What did one snowman say to the other snowman?
I don't know.
It smells like carrots.
Okay, I finally found someone who enjoys these as much as I do. Okay, good. All right, Arc, let's start talking about GBS. That's an important newborn topic. It's part of our core competencies, and we always seem to run up to it. So before we talk about GBS, let's kind of talk about chorio, because as those of you by chorio, I mean chorioamnitis, which I believe I am mispronouncing, but I don't know of a better way to do it, so I'll continue to mispronounce it. The ACOG definition of chorio. Now, before I start, for those of you at home, the gold standard to diagnose chorio is pathology, meaning you get the placenta, you send it to the pathologist, and do their H&E stains and other staining and find the bacteria and an inflammation and infection. The problem, as you all know, and Arc, you know, is you don't have time for that when the baby's delivered and the mother's in front of you. So ACOG as of, and this was, I'll read this paper too, this is the ACOG Committee Opinion, number 712, August 2017, Intrapartum Management of Intra-Amniotic Infection. They allowed us to define chorio in three kind of categories. First is isolated maternal fever. And to them, what that means is patient, a mother with a temperature of 39 degrees Celsius, which is 102 Fahrenheit or greater, with no other clinical risk factors. That alone can diagnose isolated maternal fevers, and therefore you can call that chorio. Other is 38 to 38.9 degrees Celsius with the temperature repeated after 30 minutes and it persisted. That's another way using the isolated maternal fever to diagnose chorio. The second category is suspected intra-amniotic infection. And how they define that, it's clinical criteria again. That includes maternal intrapartum fever, which they don't really define at a certain temperature for this particular one, with one or more of the following: maternal leukocytosis, purulent cervical drainage, or fetal tachycardia. That's another way. If the mother of the patient you're about to have has a fever of any type with either maternal leukocytosis, purulent cervical drainage, or fetal tachycardia, the OB may call that chorio. And the OB makes this call, whether or not it's chorio or not. And then the third way, obviously, is confirmed via pathology. And this is where problems can arise. So I've heard of cases where the OB will literally look at you as the pediatrician and say, that placenta smells kind of funny. We're going to call it chorio. And at that point, you just kind of look back at them. Now we know the criteria. That's, smell funny is not one of the criteria. So what's our role in that situation? So
I think we as pediatricians are not the ones making the diagnosis of chorio. And so we have to go by that obstetrical diagnosis. That said, in this current climate of concern for overuse of antibiotics and the concern for the alterations in the long-term alterations in the gut microbiome, I think where that comes in, so we're not going to challenge the OB in that circumstance. But if I have a baby that looks perfectly fine and has no laboratory abnormalities, and we'll talk about what those labs are that we're going to check, had a clinical call of chorio that I believe to be a very soft call, that might be a baby that I might consider transferring to the regular nursery after only 36 hours of antibiotics and not 48 hours. And that's not anywhere in any sort of guideline, but I think that's where we can have some leeway in how we treat. If we believe it to be not a correct call of chorio, we might alter what we do to the baby, but I've not challenged anybody on an incorrect diagnosis. Sometimes I'll say, really? Do you think that? Because you know what that means for the baby? That means that I've got to take him and do a workup, and then they say, oh, well, if you're going to do all that, then no. So maybe a nice challenge, but not obviously any sort of confrontational thing.
Good. No confrontations in labor and delivery. Good. So now we're going to get into GBS, and you're going to see why we talked about chorio first. But what we are looking at is Figure 9 on the CDC website from November 2010, the algorithm for secondary prevention of early onset Group B streptococcal disease among newborns. This is also in the AAP Red Book. So we're looking at this flow chart. This flow chart really describes what you need to know if you're concerned about early onset GBS infection in a newborn. So first, if you think your child that you're seeing could have early onset GBS disease and there's signs of neonatal sepsis. Now, if their vital signs are unstable, they're obviously toxic appearing, that's kind of easy for you to make a decision. According to the AAP and the CDC, you do a full diagnostic evaluation. So what does that mean to them? That means a CBC with differential, a chest x-ray if they have respiratory abnormalities, a lumbar puncture if the patient's stable enough to tolerate the procedure, and a blood culture. And it also means you do antibiotic therapy. And you all know this. If you're listening, you have probably tested medical students and residents on what antibiotics to use. But just to quickly recap, you use IV ampicillin for the GBS coverage. And obviously, if you worry about listeria, sure, that'll cover it as well. And then you want to use something for gram-negative organisms, specifically E. coli, and that's usually gentamicin. You should take into account any local antibiotic resistance patterns that may be special for you. But that's what you do if the child looks like they have neonatal sepsis. That's easy. Full diagnostic eval, antibiotic therapy. If they don't have sepsis and the OB turned to you and said, this mother has chorio, now you have maternal chorioamnitis. So at that point, you do a limited evaluation according to the CDC. So what does limited evaluation mean to them? It means blood culture at birth and CBC with differential at birth and or at 6 to 12 hours of life, and antibiotic therapy, the same antibiotic therapy we just talked about, ampicillin and gentamicin. So that's a limited evaluation for maternal chorio, blood culture, CBC with differential at birth, and maybe a CBC with differential at 6 to 12 hours of life, and then antibiotic therapy. Now, Arc, in the past or in recent history, we've been using a lot of CRP, and I have not been using a lot of CRP. So could you help me in terms of, do we use the CRP for, if you have a patient with potential sepsis or maternal chorio, is it to trend, or is there a cutoff value that would say this is more likely sepsis?
We use it to trend, and you'll see the CDC guidelines recommend testing at birth or 6 to 12 hours of age. And every center has different interpretations of that. And so what we do here and what I think is done at a lot of centers is CBC at birth and again at 24 hours to trend, a CRP at 12 or 24 hours, and then again 12 hours after your initial one. So what we do is 24 hours and 36 hours here. A CRP at birth is not felt to be helpful, is that there may be inflammation, elevation because of the delivery process itself. So that's why there's a delay. And let me just add this, that while you made the point that the pathologic diagnosis of chorio is not anything, meaning the placental pathology is not anything that we use to determine our treatment of the baby. The pathologic diagnosis of pneumonitis, which is inflammation, infection in the cord, is not anything that we use to determine length of treatment for the baby or whether treatment is necessary at all. Number one, determining need for treatment because it would be way too delayed, and two, because there is no real correlation between sepsis and the presence of pneumonitis. So more important are all the other things that we've already mentioned, how the baby looks and the other lab findings that we'll use to make that ultimate decision of how long to treat and whether to continue treatment.
All right, so now, what if we've gotten to the point where there are no signs of neonatal sepsis in our child and there is no maternal chorio? That would be good. Then we have to worry about the GBS status of the mother. And remember, OBs will check a pregnant woman for GBS between 34 and 36 weeks.
When we're talking about knowing prenatally GBS status of the mom and then determining response and treatment of the mom, all this is to prevent early onset Group B strep disease. It will have no effect on gram-negative disease and no effect on late-onset Group B strep disease. So remembering that's what you're ultimately intervening to prevent, is early-onset Group B strep disease. And so that's Group B strep disease in the infant at less than 2 weeks of age. So if the mom is known to be Group B strep positive, and most OBs will test between 34 and 36 weeks. So if that mom is negative, then she requires nothing in labor, no antibiotic prophylaxis in labor, and her infant after delivery just gets routine newborn care. So routine level 1 newborn care, vitamin K, eye prophylaxis, nothing special. If that mother is known positive when she presents in labor, then regardless of her gestational age, but she's going to be over 34 weeks because she's a known positive, all right? So she should receive penicillin, ampicillin, or cefazolin if she is penicillin allergic. And appropriate Group B strep prophylaxis is considered at least one dose greater than or equal to 4 hours prior to delivery. So if she got appropriate treatment, meaning one dose and it was 4 or more hours prior to the delivery, then that baby requires no laboratory evaluation, but should not have an early discharge. Now, an early discharge meaning at less than 24 hours, and most centers are not doing that. There is a proviso in the CDC guidelines saying that if there is good follow-up established, that you have good contact with the mom, that you know that you'd be able to track her down, or that she's reliable and would come if the baby was sick, that period of observation, the second 24-hour period, could be done at home. That's up to the individual practitioner. That is not something that we do in our center.
And it should also be noted in that proviso that the patient has to be at least 37 weeks gestation. So, Arc, the way I understand this, if the mother's GBS unknown, she just gets off of a plane from another country and you have no medical records, or she never went to see an OB for prenatal care, you would treat her as if she's GBS positive because you don't know, meaning you would need to get antibiotic prophylaxis greater than or equal to 4 hours prior to her delivery with penicillin, ampicillin, or cefazolin. And if she got that, then you could use the same observation for greater than or equal to 48 hours unless we met the proviso. Is that right?
So that's correct, but she may also be unknown because she is less than 34 weeks gestation and not necessarily traveling from another country, so off an airplane. So if that's the case, because in that circumstance, a subclinical choreo may be the cause for her early labor and delivery, then you would treat her as a positive, and her baby, so you would begin prophylaxis in her, but her baby would also get an evaluation and treatment. So a preterm baby under 34 weeks of gestation with spontaneous onset of labor, that baby is considered to possibly be infected because mom possibly went into preterm labor because of a subclinical choreo. So all those babies get an evaluation and antibiotics.
I didn't know that. So then if that kid, if there's spontaneous labor, which causes the child to be born under 34 weeks, you treat them that there's a potential for GBS, early onset disease, and you would rule them out. And you would use antibiotics.
Correct.
Okay. All right. So now if the mom did not get the antibiotics, she's known GBS positive, and she did not get antibiotics. She came in, this is her third baby, 2 pushes, boom, baby out. And that's all it took. Then, as long as the child is greater than or equal to 37 weeks gestation, and the duration of membrane rupture was less than 18 hours, which is why I used the example I did, then you could observe that child for 48 hours, greater than or equal to 48 hours, as per these CDC guidelines. And of course, they have caveats which should be obvious to you, but we'll just say them quickly. One is if the baby gets signs of sepsis, you should do a full diagnostic evaluation and give antibiotic therapy, and you all know that. And the second one is for those babies greater than or equal to 37 weeks gestation and their rupture of membranes was less than 18 hours, some experts will recommend the CBC with differential at 6 to 12 hours, and that's up to your center what you all do. And then so then that would mean the opposite, well, not the opposite, but if the child was less than 37 weeks gestation, or they had rupture of membrane from longer than 18 hours, and mom did not get antibiotic therapy, and she's GBS positive, then she would get you would get a limited evaluation on that patient, which we already defined, which is blood culture at birth and CBC with differential at birth and or at 6 to 12 hours of life. And you would also observe this child for greater than or equal to 48 hours. And again, they put the same caveat, which you should know, which they can put with all these things, which they almost do, which they do, that if signs of sepsis develop, you do a full diagnostic evaluation and antibiotic therapy start. All right, did I say that right, Arc?
So you can have this chart hanging in your nursery, which is probably not a bad idea. But if you want to think about how to think about this, if a baby is born and looks sick, regardless of mother's Group B strep status, you're going to do an evaluation and put them on antibiotics, right? If a mom has been diagnosed as choreo by the OB, again, regardless of what that baby looks like, you're going to do an evaluation and you're going to put that baby on antibiotics. And the difference in the evaluation between the sick-looking baby and the well baby and all these other circumstances is that an LP is recommended if the baby is ill appearing, but well enough to tolerate. So ill, but not too ill that you think they wouldn't tolerate the LP. The LP is not recommended for the other evaluation. So those are limited evaluations without an LP versus a full evaluation. So again, I'm sorry, but just to reiterate, so if the baby looks sick, regardless of maternal status, you're going to do a full sepsis evaluation and start antibiotics. If the mom has a diagnosis of choreo before the delivery, regardless of how the baby looks, you're going to do a limited evaluation and start antibiotics. Now, the other things does depend now what the mother's Group B strep status was. So if mom is Group B strep positive and appropriately prophylaxed, nothing other than routine care is indicated for the baby, but not usually less than a 48-hour discharge. Again, there's the option to discharge at 24 hours. If the mom is Group B strep positive and did not get prophylaxis, but the baby is over 37 weeks and under 18 hours of rupture membranes, nothing other than observation is necessary. But if she is positive or unknown and the baby is either less than 37 weeks or there was rupture of membranes for more than 18 hours, now a limited evaluation is again recommended because the risk of infection in those circumstances is a little bit higher, and observation and not an early discharge as an option is recommended. If a baby is born at less than 34 weeks, so in those circumstances you are not going to know Group B strep status, the presumption is there's a possibility for choreo as the cause, and those babies all get a workup and treatment with antibiotics for at least 48 hours.
Now, if you're listening in the car or listening at home, this is hard to do without a figure in front of you. I'm hoping we kind of broke it down and repeated it a number of times that helped. If it was too confusing, I'm sorry. It's just challenging because this is an algorithm, and we've tried to break it down as best we can. But this is now early onset Group B GBS workup and concern in a newborn, as per the CDC and the AAP.
And just one more thing, Tony, just to point out how much this Group B strep screening of mothers and intrapartum treatment of mothers has affected the rates of early onset GBS disease. Before universal screening of mothers came into play in the mid-90s, the case rate of early onset GBS disease was 1.7 per 1,000 live births. The case rate of late onset GBS was around 0.4 cases per 1,000 live births. Since we have implemented the universal screening and treatment, currently the last statistics I have here from the Red Book are from 2008. The rates of late and early onset GBS are roughly the same at around that 0.3 to 0.4 cases per 1,000 live births. So we've really made a big impact in that.
But we haven't affected late onset.
But you haven't affected late onset. So right. So my point of saying is the early onset has come down to about the same rate as the late onset.
That's great, Arc. Thank you for that. What I have realized at this point is we will not be able to get through these core competencies in this one podcast. There's just no way. Each core competency specific line, there are a number of them that we could talk about for an entire hour. So it's going to be impossible to do this in 1 hour. So this is going to become a first series of podcasts that I do, trying to get through the newborn care and delivery room management core competencies. And I hope my guest Arc will join me for the rest of them, if she's able. So now that's GBS. We're going to transition to neonatal hypoglycemia. So first, for neonatal hypoglycemia, it's not a specific core competency. What we're doing is taking it from a couple different ones. There's one that's lists the clinical indications for an acute metabolic or endocrine workup in a newborn, and then another one that's review the basic physiologic differences between the preterm and term infant, attending to cardiopulmonary needs, respiratory control, feeding issues, which is where this comes in, and other elements. And then discuss the impact of maternal factors on the fetus and newborn, including abnormal prenatal labs, maternal diabetes, thyroid disorders, and prescription and non-prescription illicit drug use. So it's a part of those three, but it is important enough that we really need to discuss it. So we're going to start with, and this is an area that gets controversial. So we're going to start with what's agreed upon, and then we're going to move into the controversy. And at the same time, we're going to be reviewing what the AAP recommends. So first, let's discuss the areas of agreement. So what we're talking about right now is, I'll be very specific, we're looking at the AAP's clinical report, postnatal glucose homeostasis in late preterm and term infants. This was published in Pediatrics. This was volume 127, number 3, in March of 2011. So we're going to talk about late preterm and term infants and glucose homeostasis. So what's agreed upon is that recurrent severe hypoglycemia can cause brain injury in your neonate. So coma and seizures may occur with prolonged neonatal hypoglycemia, which the AAP in their paper define as plasma or blood glucose concentrations lower than 10 milligrams per deciliter, and repetitive hypoglycemia. Now, the more severe signs, which are coma and seizure, usually occur late in severe and protracted cases of hypoglycemia. And the interesting part is they're not easily or rapidly reversed with glucose replacement or normalization of sugar. So as you know, if the child is hypoglycemic and seizing, the first thing you do is reach for glucose. You would go for your D10W to try to bolus them, and just as 2 cc's per kilo bolus. And what you would find is that it doesn't necessarily stop the seizure. Now, let's review the clinical signs of neonatal hypoglycemia in general, because I'm sure that's something we need to know. First, there's jitteriness. Then you can see cyanosis. We talked about seizures. Of course, apneic episodes, tachypnea, weak or high-pitched cry, floppiness or lethargy, poor feeding, or even eye rolling. Those are the clinical signs of neonatal hypoglycemia. Just a quick recap: jitteriness, cyanosis, seizures, apneic episodes, tachypnea, weak or high-pitched cry, floppiness or lethargy, poor feeding, or eye rolling. Now, let's talk about where there's controversy, and then we're going to move into what the AAP discusses in terms of the screening and management, and then we'll get into the controversy a little bit more in detail. The big controversy focuses on, for these kids, these late preterm and term kids, first of all, who's at risk, which we'll get to, but what glucose level should be used to define hypoglycemia in neonates, meaning what is actually low, and there's not really agreement on that. And does episodes of low blood sugar or hypoglycemia in these kids that may occur once or twice actually cause an issue or not, or is this part of their normal physiologic process? We're going to get into that. But first, we have to learn and review how to screen and manage these kids. So the kids we're talking about are those in late preterm and term. Now, they're term small for gestational age or increased risk for neonatal hypoglycemia. Infants of diabetic mothers are at increased risk. Large for gestational age infants are at increased risk. I'm going to just review this table because that's what we've been doing for these protocols. So for those kids, you're going to screen them.
So here's the most important thing, and when these guidelines came out in 2011, believe it or not, our practices had been to identify babies at high risk, check a blood sugar, and if they were low, then act. Now our focus is on identifying who's at risk, early feed. Don't wait for that baby to be low before you act. Identify them as being at risk for hypoglycemia. make sure they are fed early, and by fed early, that means within an hour after delivery, and then monitor according to the guidelines that Tony, you are going to go over now. So identification of the high-risk baby is number one in thinking about treatment of hypoglycemia.
Thank you for that, Arc. So now we've identified who we have. We are going to feed them. Who should we worry? What number should we worry about? We're going to get to. So birth to 4 hours of age, just like Arc just said, you initial feed within 1 hour. You're going to screen glucose 30 minutes after the first feed. The initial screen should be greater than 25, ideally. If it's less than 25, you're going to feed again and recheck them in an hour. If it's still less than 25, you're going to give IV glucose. For this, what glucose would you use? We typically do a bolus and then put them on maintenance and check the sugars. There is some controversy to that as to whether a bolus is necessary or if elevating the blood sugars that high could have a detrimental effect. But for us, for the guidelines, we're going to just do a bolus and do maintenance fluids. And then just to recap those numbers, the bolus is 2 mLs per kg of D10W, and the maintenance is D10W at 80 to 90 mLs per kg per day.
So that works out roughly to the maintenance glucose requirements for an infant, which are 6 to 8 milligrams per kilo per minute.
What Arc's talking about is a dextrose infusion rate. So 6 to 8 milligrams per kilo per minute, and that's specifically for growth-restricted infants. And some of them are a little different depending upon who we're talking about, right? So infant of diabetic mother, you'd want to do 3 to 5 milligrams per kilo per minute.
So that 6 to 8 milligrams per kilo per minute is pretty much maintenance glucose requirements for any newborn infant. Oftentimes, infant of a diabetic mother, a baby who is in a hyperinsulinemic state, because of that, often will end up going over 10 milligrams per kilo per minute in those babies.
Is that right?
Yes.
So you wouldn't worry about overstimulation of the insulin secretion for those kids at all?
So the reason that you don't just bolus, the reason that you bolus and begin maintenance IV fluids is so as not to have that Somogy effect that can happen from just a single bolus. We worry about the concentration that we give peripherally because it can be irritating to the veins. So that's why peripherally we don't give anything over D12.5. So going back to our issue of can a baby stay at your level 2 nursery? If the baby requires a concentration of dextrose over D12.5 to provide the proper glucose infusion rate without giving too much fluid, if they require something over D12.5 that would need to go through a central line, then that's a baby that may need to be transferred if your unit cannot maintain an umbilical venous line or a central line like a PICC line.
So let's finish what we're doing because I want to get back to you and talk about a little bit of symptomatic treatment. So, all right, so where were we? So we've been birthed to 4 hours. We identified our high-risk infants. We fed them. We rechecked them 30 minutes after the first feed. We fed them within the first hour. The initial screen was less than 25. If it was more than 25, we were happy. If it was less than 25, we refed them and rechecked in an hour. If it's less than 25, again, IV glucose. If it's 25 to 40, we're going to refeed and use IV glucose as needed.
It may also be difficult to get a baby within a few hours of life to take 2 or 3 feeds as the steps in the protocol require. So an NG feed would also be an option if you can't get the IV in or you prefer not to put the IV. So if the baby won't take again, you could continue treatment with an NG feed.
And we should say that this was we're talking about asymptomatic infants. If at any point your infant is symptomatic with a blood sugar less than 40 milligrams per deciliter, and again, 40, if you're wondering where that number came from, what I've discovered is it was just arbitrarily chosen by expert opinion. There's no real evidence behind it, and there's starting to be some, which we'll get to in a little bit. If they're symptomatic with a blood sugar less than 40 milligrams per deciliter, you would then go to IV glucose. And I guess, Arc, my question to you is, how symptomatic? So what if they're just jittery?
So jitteriness alone probably wouldn't prompt an IV placement if you could get a good response with a feeding. But you also have to keep in mind that those symptoms that you read, the symptoms of hypoglycemia, are all very nonspecific, right? Lethargy, jitteriness, eyes rolling back, those a high-pitched cry, those are symptoms of sepsis. So at that point, you not only may be considering whether to place an IV or a central line if you can't get this glucose up over 25 or ultimately 40, but you may also be considering a sepsis workup because the hypoglycemia can also be rolled into an early infection.
Thank you again, Mark. That was a really great point. Along with that, according to the AAP clinical report that we've been going through, one of the things they do mention that if you can't keep the blood sugar for the infant above 45 milligrams per deciliter after 24 hours of using this rate of using a normal rate of glucose infusion, you should consider the possibility of hyperinsulinemic hypoglycemia, which according to this paper is the most common cause of severe persistent hypoglycemia in the newborn period. I'm assuming they took sepsis into consideration there and it just wasn't perhaps severe and persistent. Maybe after you treat the infection, the blood sugar improves. But that's what the AAP clinical report from 2011 says. All right, so now what if you've gotten past the birth to 4 hour phase? We've talked about birth to 4 hours. So 4 hours to the first 24 hours. You're going to continue feeding the infant every 2 to 3 hours, and you will screen the glucose in these high-risk infants. Again, term small for gestational age, late preterm kids, infant of diabetic mothers, and large for gestational age infants. You're going to keep screening them prior to each feed. If any of the screens are less than 35 milligrams per deciliter, you feed and recheck in an hour. And as Ark said, if you can't get them to feed, an NG tube feed may work. But at that point, from 4 to 24 hours of life, if they're less than 35 milligrams per deciliter, you would do IV glucose, and we've talked about that already. If they're 35 to 45 milligrams per deciliter, you're going to try and refeed after that hour and check their glucose again. And if you can't get them to refeed, consider IV glucose at that point. So now we've kind of walked through this figure 1 in the AAP clinical guideline, clinical report on postnatal glucose homeostasis in late preterm and term infants, isolating who are the high-risk infants we're discussing. And then one of the things that came up when you look at this report and read it, how long should you screen? What they say is until 12 hours of age, you should keep screening for infants born to mothers with diabetes and large for gestational age, but until at least 24 hours after birth for late preterm infants and small for gestational age infants. So they do make that differentiation. A late preterm or a kid small for gestational age, you'd screen for the full 24 hours. If one of them was large gestational age or was an infant of a diabetic mother, you could stop at 12. But Ark, is that your experience?
We tend to screen them at our center. We tend to screen everybody for the first 24 hours.
So when we talk about this, one of the things we have to ask ourselves is where do all these numbers come from and how much evidence is behind this? And one of the more interesting articles I read was an editorial by Dr. Christopher McKinley, and this was on JAMA Pediatrics, and I'm going to go through the article he talked about. But it's an editorial he wrote. It's called Revisiting Transitional Hypoglycemia. Only Time Will Tell. JAMA Pediatrics, October 2015, Volume 169. He says current practice is based largely on expert opinion, which for almost 50 years has been divided as to whether transient low glucose concentrations in otherwise healthy newborns represents normal physiologic variation or a marker of inadequate metabolic adaptation with risk of injurious neuroglycopenia. And what he's really saying is we don't really know to what level, what number below we're going to get injury, or if all of this is just normal infant behavior. To make that a little clearer, we're not talking about the infants who have severe hypoglycemia and then symptoms such as seizure, coma, etc. We're talking about these at-risk infants if they have 1 or 2 events of hypoglycemia and they're not symptomatic. Does that actually cause any harm to them? And we don't know. And we don't know if the fact that they get hypoglycemic, these at-risk infants, the large for gestational age, small for gestational age, late preterm kids, if they get hypoglycemic and not symptomatic, if that's just a normal part of their physiology and we're making a big fuss about screening them for nothing? That's a very hard question to answer, and in the literature it's being debated, and there is not an answer as of yet, as far as I have read. Now back to Dr. McKinley's editorial. He was commenting on an article in JAMA Pediatrics, same journal. It was October 2015, volume 169, number 10. The author is Jeffrey Kaiser, Sasha Bai, Neil Gibson, Greg Holland et al. And the article is termed Association Between Transient Newborn Hypoglycemia and Fourth Grade Achievement Test Proficiency, a population-based study. What they found was rather interesting. The study showed that a single episode of hypoglycemia was associated with a significantly decreased probability of proficiency on fourth grade achievement tests in literacy and mathematics, which is startling and surprising. But remember, this is a retrospective observational study, and those are fraught with issues, which Dr. McKinley wrote and discussed, saying the limitations include little information about management strategies for the hypoglycemia, no rates of breastfeeding, which may be important confounding factors. Did the exposure group have a single episode of hypoglycemia because only the first two blood sugars measurements were evaluated? So there's issues with the study, but the finding is interesting because it adds a little bit to the debate. So along those lines, then McKinley did a paper in the New England Journal of Medicine. This was by Christopher McKinley, Jane Allsweiler, Judith Ansell, Nicola Anstis et al., and they're with the CHYLD study group. This is in New England Journal of Medicine, October 15th, 2015, so right around the same time, volume 373, issue 16, titled Neonatal Glycemia and Neurodevelopmental Outcomes at 2 years old. So this study showed basically the opposite. Now, this was a prospective cohort study, involved 528 neonates, gestational age of at least 35 weeks, who were felt to be at risk for neonatal hypoglycemia, because again, they were infant of diabetic mothers, large for gestational age, preterm or small for gestational age. And they found that their rate of neurodevelopmental delay was not different between the group that experienced a hypoglycemic event compared to the group that did not experience a hypoglycemic event. But this also doesn't close the door on this issue. This issue is still, both authors have commented that this issue is still controversial, and we're not definitely decided on, does neonatal hypoglycemia, one or two events, amount to normal physiologic status, amount to potential damage to the nervous system, and how and at what level and how much does it do? Arc, what do you think?
So the only thing I can think is that we have to look at the quality of the data. Both of those studies were published in reputable journals, but when given choice, looking at these two, I'm always going to put a little more stock in the prospective study, and that study was a cohort study and not a controlled study, so even that is not the highest quality of data. But I think for now I'm going to err on that side, and maybe because it's just too scary to think about that all these kids that we don't even know are hypoglycemic very transiently are having some sort of long-term effect, and there's nothing we can do about that. It's almost that we don't know what we don't know. Interestingly, also, the McKinley study, he uses a continuous glucose monitoring device, which most NICUs are not using. So we don't clinically have access to those kind of devices.
All right. So now we've walked through the AAP clinical report on postnatal glucose homeostasis in late preterm and term infants. We've talked about what the AAP tells us, which is, if we're going to, my assumption, again, it's an assumption, I know nothing about this test. If they're going to test us on something for the hospital medicine exam, the AAP clinical reports and guidelines are for certain going to be there. And then we've talked about some of the controversy. We've talked about some of the known information. I think we're good for now in discussing the neonatal hypoglycemia. Ark, did you want to add anything on this?
I don't think so.
Let me ask you an off-the-cuff question, Ark. For these exams, for you all, for neonatology, is it that you're expected to know all the latest literature, or that for certain these AAP clinical reports and these AAP guidelines have to be absolutely known, and then kind of where the literature is in general?
No, most board exams are not asking you about issues that are undecided or around which there is controversy. So the questions, the testing will be around knowing response levels for hypoglycemia, recognizing signs of hypoglycemia, but not so much around long-term outcomes of kids with hypoglycemia, because as you just went through, there's still much discussion about that.
All right, let's move on to the next section. You know, Ark, before we move on, I just wanted to let you know my dog has been chasing people on a bike.
Oh, that's horrible. What'd you do?
Well, I got so bad to take his bike away. All right, now let's talk about thyroid disorders in terms of the mother, in terms of the infant, screening, all of that. That's something that comes up quite a bit. And again, just if you're keeping track, we've roughly done 4, maybe 5 of these core competencies for neonatology. So these are going to take a while for us to go through. So we may have to cover these over the course of a few podcasts, which is fine as long as doing what you, the listeners, want. So as always, I'm going to take this second now to say, please feel free to email me at tony.tarchichi, that's tony.tarchichi at chp.edu. If you have comments, recommendations, complaints, compliments, anything about how we're doing and what you're listening to, I'm happy to adjust based on what the listeners want. Along those lines, we will be releasing a survey in the next couple of weeks that I'm going to ask anyone who listens to me somewhat regularly to please fill out. It'll allow us to figure out how we're doing, how people are taking these podcasts. Do they like them? What would they like differently? Just so I know who's listening in general. It will be anonymous, and it will be very anonymous because I don't need to know where you are or who you are, nor do I care to know. But I do want to know how you feel about the podcast and then what we can do to make it better for you. Because, again, this is a labor of love, but I want it to be as good as it possibly can. Okay, Ark, let's talk about let's talk about the thyroid.
So it's important to know if a mom has an autoimmune mediated thyroid disorder. So the most common cause for thyroid disease is still iodine deficiency, but that's easily treated and usually identified. And so if you are in an area where this is prevalent, you would know this. But the tricky part is if mom has an antibody-mediated immune disorder, and treated or untreated. I've seen this where maternal Graves was not reported to us because mom had had a thyroid ablation and was no longer on therapy. Mom still had antibodies, and antibodies got passed on to the babies. So just keep that in mind. And even though there's a past history, those antibodies may still be present. And so we routinely screen all babies in the nursery. I think every state, I was going to say most states, but I think all states now, as part of their newborn screen, have thyroid screening. But that aside, if you know that mom has autoimmune thyroid disease or has anything that blocks activation of the TSH receptor, we know that these can cross a placenta and may take 3 to 6 months to resolve. And so any abnormality in testing in the infant would consult endocrinology. Again, you likely have, even if you're at a level 2 where the baby doesn't need true NICU care, you probably have available to you a consultant to help with that. So for maternal hypothyroidism, just paying attention to your newborn screen is probably the main thing you need to do, because symptoms of hypothyroidism in the baby will likely not be too evident. Babies born to moms with Graves' disease, though, may present to you with thyrotoxicosis, and so it's important to know what those signs are. So a neonate with hyperthyroidism may have tachycardia, hypertension, tachypnea, increased temperature, feeding difficulties, irritability, diarrhea, flushing. So things that you would see in an older child or adult. They may also have the eyelid retraction and stare that we think of with older kids and adults. And in severe cases, you may even see hepatosplenomegaly, low platelet counts, jaundice, cardiac failure as part of the thyrotoxicosis presentation. So what I'd really like to make sure that everybody pays attention to is that even a mom who had a thyroid ablation and now is on thyroid replacement therapy can still have these thyroid antibodies that would cross the placenta.
The last part, anti-thyroid drugs, if they're like methimazole or PTU, propylthiouracil, if they're given during pregnancy to treat maternal hyperthyroidism, they can transport across the placenta, and that can cause transient congenital hypothyroidism until the drug is cleared from the infant's circulation normally, and that takes about 7 to 10 days. Now, we have a little bit of time. Arc, let's talk about one of the more general questions that I find these are always hard to answer. And it says, describe the skills needed to be an effective resuscitation team leader, including critical thinking, evidence-based decision-making, and the use of continuous quality improvement principles. I mean, I feel like they tell you what the skills are in the question stem. So I don't know what to say about that, but if you had anything you wanted to say, I'd love to hear it.
So I think we touched on this at the very beginning. I think that the way you're going to be prepared at the level 2 nursery for when the emergency happens is by making sure, and it might be months or even years before this happens, but by making sure that everybody has their NRP certification. And again, while we don't expect the OB to lead the resuscitation, you may need that person to be an assistant to you. So when you turn to them and say, get me a UV line, that person knows where they are. And what they are. And while you may have competent level 2 nurses with you, we all know that in an emergency, people are running all over the place. So even if it's a place that does not ordinarily handle a 24-week baby, they ought to at least recall, oh yeah, Tony told me that he's going to need a bag, a plastic bag to keep this baby warm. Let me find out. You don't want the first time that they hear, I need a bag to keep the baby warm, when that baby is delivering in your delivery room. So preparation, making sure everybody is NRP certified. I think that that's how you become an effective team leader, by making sure that your team is able to support you.
Okay, so on our last count, we have checked off 1, 2, 3, 4, 5, 6, 7 of the knowledge sections on the core competencies for newborn care and delivery room management. We are out of time, so we're going to do one more of our corny jokes, and we're going to do our finish. I'll let you start this one.
Why does a chicken coop only have 2 doors?
I don't know why.
Because if it had 4 doors, it would be a chicken sedan.
What did the tomato say to the other tomato during a race?
I know.
Ketchup. All right. We are out of time for today. We are going to pick up where we left off at our next podcast. So now we're going to do our exit. First of all, I want to thank my guest again, Dr. Arcangela Balest. I appreciate your time. This was a really fun podcast. Thank you for joining me.
Thank you, Tony. It was a pleasure.
And for acknowledgments, I have to thank my group, the Paul C. Gaffney Division of Pediatric Hospital Medicine here at Children's Hospital Pittsburgh, for continuing to allow me to do this. To all of my listeners, wherever you are, thank you very much for listening to us every time we put out a podcast. I sincerely appreciate it, but please feel free to email me with anything you may have. And also, as always, I'd like to thank Dr. Megan Keene Tarchichi, who always helps me with everything. And I'm going to leave our information one more time. My email is Tony, Tony.Tarchichi, Tarchichi, @chp.edu. Feel free to email me. Thank you all very much. We will try to get the next one out to you as soon as possible, but just as you're super busy, so are we. So please have patience and bear with us, but we will be releasing them all. Thank you very much, everyone. You have a great day. Hope winter ends soon.